Today, mainly I will focus on the 2.6 French tapered along microcatheter, which for me outperform all the microcatheters on the market. I have used all available microcatheters on the market, not once, not twice, maybe more than 50 times. So I think I have a say on this, and I will explain it later with a lot of examples. So CTO PCI is the Mount Everest in complex PCI, or in other words, it's the Formula One in complex PCI. You need good cars, you need good drivers, and in CTO PCI, you need good microcatheters, you need expert operators. So I will go antegrade first. I will give you some examples why I'm working with this microcatheter. And this is an antegrade approach. And this is a braided microcatheter, couldn't cross the lesion despite anchoring. And here comes the 2.6 French along microcatheter. In antegrade, I usually use 2.6 French 130 for antegrade passage. What strikes me with this one is as it gets easily into the proximal cap and gives support by itself to the guiding catheter. If I compare among its kind, on the contrary, Corsair, Turnpike, Mamba is a liability to the guiding. You need real support. And along moves nicely, and here you can see the end result here. So this is another example, antegrade example. So normally in this case, everyone would have begun with an anchor or with a guide extension. But I am pushing along 2.6 to the limits. I want to know what's in this microcatheter. This is one of the cases I put the microcatheter on test. And here you can see this is again a 2.6 French microcatheter. And you see the guiding catheter here on the left screen, on the right screen, how it's popping back into the aorta. But you see also the 2.6 French along has its head in the lesion and it going down easily, and not easily, but surely and slowly. So here is what is going on. We crossed the first obstacle, still no guide extension, no anchoring, and here still we have to cross the main branch with Gladius, and here we are in the check true lumen, desolation with Gladius, and then we are going down without any anchoring, without any guide extension, down to the distal vessel here. And another thing with this along microcatheter, like I normally use 7 French, but if you want to use 6 French, then it comes out with a guide extension, okay? The microcatheter has a guide extension, and I have used guide extension here to test this as well. And this is another additional benefit of using this along microcatheter. So I think the magic lies between the structure of the microcatheter. The even coil provides better axial support. That's the reason why it gives extra support to the guiding catheter rather than pushing back the guiding catheter. And the PTFA inner layer, as you mentioned, it prevents biting the wire, trapping the wire. So even in tortuous anatomical positions and tortuous vessels, you feel that the wire is not going easy, but it's not stuck. I haven't encountered any stuck in the microcatheter with along. I have experienced this wire stuck in the microcatheter with every microcatheter, okay? With Corsair, Corsair Pro XS, Mamba, Mamba Flex, with all of them I have experienced them. Maybe this is the reason the PTFA inner layer is the answer. I don't know. So here is the expressman action. I go, and here you see the final result of the antegrade approach. So, and this is a live case. Not only antegrade, of course, I use the 2.6 French mostly in retrograde. Antegrade, of course, but mostly retrograde. This we squeezed 2 live cases in a in the Optima Istanbul CTO meeting, and this is one of the examples. You see this tortuous collateral here, and then I used along 150 again, and we're progressing in the septal, and here is the tip injection coming, and then you will see how tortuous the septal is, and it's bending over the apex, and it's not easy to cross with a microcatheter, even with a braided microcatheter, this kind of tortuous curvatures. And here we knuckled it down, and then you will see how easy the microcatheter will go into the distal part. And another, this was another thing. Normally, if you go with your wire into the guiding catheter, into the antegrade guiding catheter, you trap the wire, okay? Because you want to go with your microcatheter into the guiding catheter. But just to put this microcatheter on test, I didn't do that. You will see the ultimate bros will go into the guiding catheter on the left panel here, and then you will see how the along 2.6 French will push the guiding catheter back, changing the coaxiality, and then you will see, without trapping the ultimate bros, this along 2.6 French guiding microcatheter went into the guiding catheter. And then another feature is what I experienced, this is my humble experience. Maybe Alex has also a lot of experience with this. Maybe he can enlighten us after my speech. And you see the microcatheter is there. It's like a solid rock in the guiding catheter. You don't need to trap, or you don't need to pin the microcatheter in order to prevent prolapsing back into the vessel. So and now it comes the externalization wire here, and after the externalization, this is the final result. This is another case. We failed this case before, and I choose this as a live case. It was a challenge for me, and then I will show you what we have done here. And we had a lot of difficulty, of course. Again, along 2.6 French, 150. Here comes again our septal surfing with cyan black, I think. Yeah, this is cyan black. And then let me show you, what can I show you different in this case here. Not the surfing, of course. Yeah. Another thing is tracking I think the most important thing in this guiding catheter is the extra support that it gives to the system. If you see, we are preparing antegradely now, along 150 retrograde, along 130 antegrade, 2.6 French, and we are doing preparing with filter XT. And then you see on the left panel how the antegrade 130 microcatheter takes the curvature and goes into the distal vessel. And here what we are doing expressman reverse cart. You will see the gladius will go into the guiding catheter, retrogladius in the expressman, and then in the guiding catheter. And then what we will show, this is the end result. So I will go fast because I will show you something different here. I go fast. Yeah, this was again suo crossing, and it was not easy with this one. Normally, we have, for septal crossing, we have braided microcatheters like fine cross, right, like Caravel. And my experience is that there were lesions I couldn't cross with Caravel with fine cross, but with Pronavi 1.9. But in this case, Pronavi 1.9 couldn't cross, and an Artemis 1.0 balloon couldn't cross either. So I wanted to dilate the septals, but it didn't work. And I wanted to put another test on this along 2.6 French, and then you will see how this along 2.6 will behave here. It will come, and then it took me 15 to 20 minutes, but I insisted and persisted to make this microcatheter go down. And then you can see it has a turn there, and then it's in the distal vessel. And again, with this PTVA layer, I think if you make such a turn, if you squeeze the microcatheter, especially the tip, then you have difficulty, and sometimes you have to take all the systems out of the coronary. So it's not what we want. But with this one, I hadn't experienced, and I have used this microcatheter more than 150 cases. So my experience in this is very promising. So what I am doing here now is again along without trapping the wire. I am not trapping the wire here again. And my microcatheter goes right into the guiding catheter without trapping. It's not the usual way, but these are tests that I put on this microcatheter. Normally we trap the wire to have a better support and then go into the guiding catheter. But these are very fascinating for me. So here, again, along sitting there in the guiding catheter, also stabilizing the antegrade guiding catheter, and then you externalize balloon. And you should not be afraid of this appearance here. This is not a rupture. This is the dilation effect, channel dilation effect of the microcatheter. And on the right screen, on the left screen, you can also see what kind of channel this microcatheter has created in this case. So this is the end result. So I go fast, and this one is very interesting. And in this one, I couldn't go with the caravel. Here, the caravel is not going, and the guiding catheter is pushing the left main guiding catheter into the aorta. I have a lot of difficulty. It was another opportunity for me to test the along 2.6 French. So here comes the along 2. This was 170 actually. They had also this version, but then you are run out of wire, so it's not so practical. But that's what I had at that time. So I crossed it with this microcatheter again, and then Gladius EX in the guiding. You see here on the left panel, and then again along into the guiding catheter. The rest you know, RG3 and wire externalization, and it creates channels. If you have even a CC0 channel, if you introduce this guiding microcatheter into these septals, then they create real channels. So this is the end result. This is my last example here. This is also an example to give you another idea how supportive this microcatheter can be. This is again a retrograde case, antegrade vessel preparation, and then we crossed again retrogradely without trapping the wire, and then we did a tip-in technique. We tipped the wire, retrograde wire, into the antegrade 130. This was an along 150, antegrade 130. Now we did the tip-in. And with tip-in, everyone knows that if you push antegradely the microcatheter, you have a lot of difficulty, support difficulty problems, okay? You feed the back of the microcatheter with a wire, or you try something different. But usually you have always problems when you do that. But with this one, you will see how easily it will go antegradely without even feeding the microcatheter with a wire. So my understanding, what I want to know is what gives this microcatheter this support. I think it's the structure with the axial support, this even coil technology. So, and this is so then what we have done is, you know, the usual thing, a long dual microcatheter going into the PL, and I will show you and then we did DEB, just DEB without stanting, and I will give you the last result here, and this is the end result without stanting, just DEB. So I will summarize my talk. And I think it's the even coil that gives the axial support to this 2.6 microcatheter, which is my default microcatheter in CTO PCA. It doesn't matter antegradely or retrogradely. And this cross-enter-sit maneuver of this microcatheter is for me fantastic. And the tip with the PTF inner layer prevents the wire to squeeze in the microcatheter. So I think it's also unique in this manner. Thank you for your attention.
So really, really interesting. And I'm very happy because I'm like you. Means this is also my microcatheter, the 2.6, okay, only. And so why, as you said, there is some support? Because it's a mix between Corsair Pro and Turnpike spiral. But the spire of the microcatheter are not so externalized than the spiral. That's why we can use it retrogradely. And that's why it provides you a lot of support when you are inside the CTO segment. So really interesting. So now I want to ask you some question. Who here is doing retro? Okay. And do you use the same microcatheter when you work antegradely and retrogradely, or do you use a specific microcatheter antegradely and another one retrogradely? So we use the same microcatheter.
I have used the micro just for antegrade cases.
Okay.
No, I haven't experienced it for retrograde cases, but I'm really happy. I was really happy to use it, and even for 1.7 and 1.9, the flexibility was great. The flexibility from the CTO body was great and surprising for me.
Okay. So yes.
Lower profile was retrograde, like for example, caravan. Lower profile.
Yes, I understand. I'm just approaching you because I want to answer you after. So, okay, so because this is the main talk about everyone, and you will see during MLCTO, a lot of CTO operator will do maybe retro with low profile microcatheter, because they said it's a low profile, it will cross easily inside the collaterals. Then I need to remember you the past of the CTO, which was the first microcatheter we had long time ago.
Corsair.
Fine Cross and Corsair. Okay? Corsair is 2.6. Okay? With which one we did the first retro? Corsair.
Yeah.
Okay? Corsair was used always for retro. And we don't care at this time that it was a low-profile microcatheter. And it crossed in most of 90% of cases. Okay? It means this is only a story of some people who are who like the low-profile microcatheter, but 2.6 tapered microcatheter as the Elong or the Corsair Pro. The name was septal dilatator before the Corsair, because the tip is very thin, and then it can you can cross inside the septal. So it's only an illusion to say that only low-profile microcatheter could cross retrogradely. And why I told you that? Because where I'm working, all my patients are very calcified. Okay? So it's not only the problem to cross the retro, it's the problem after to puncture the distal cap and to cross inside the calcified part with stenosis, occlusion, and go on. And I can tell you that the Caravel is not able to do that. Okay? Low-profile microcatheter are not able to do that. They are very good crossing the septal, okay? But then after, if you want to puncture, there is no support. So that's why it's my micro in my lab, because with this one, I can have both. In more than 90% of cases, I can cross retrogradely. And then I'm ready to have my supportive microcatheter to puncture retrogradely. So in the 10% where this microcatheter, unfortunately, the profile is not so good, then I can use a low-profile microcatheter. But I can tell you that most of the time, the low profile is not crossing anymore also. Okay? So it's just to tell you that it's not because you are doing retro that you need a low-profile microcatheter. Yeah.
Do you think is the support you get from this microcatheter, which I feel it is, it's not braided all the way from the beginning to the end, is only the tip of the 2.6, so it's actually heavier in the proximal side of the microcatheter rather than so when it goes in, it gives that, when you use it, gives that push through the narrowing or the cap.
Yeah.
It penetrates easier, and as you demonstrated in your cases, the guide is not actually falling because I feel it is heavier down the bottom of the macrocatheter as compared to the beginning of it. as compared to the rest of the other microcatheter, they will be exactly braided from the top to the beginning. So it's all the, there's no difference. It's the same size.
You're right, but also this is because it's some spire at the start, and then you really increase your support in
and the talkability of clockwise and anti-clockwise is possible with this.
Yes.
Where some of the Corsair, it's only anti-clockwise, clockwise only with the turnpike. With this one, you could actually go on both sides.
Can you show it?
Exactly.
Can you show this one? Can you show this one? Just this one.
First option, or
Yes. If it's
No.
If it's a very, very not tortuosity, but the size. So if it's a really small epicardial channel.
So Alex, could it be also that the hydrophilic part is not so long as with Corsair, even Corsair Pro? Because if you turn it, okay, you transfer the energy forward, okay. If there is resistance, then it will go back, and then you have your follow-flow guiding catheter because it's more lubricious. Could it be also another reason that this length, hydrophilic length, is not so much as the Corsair Pro or the Corsair? Could it be another reason? That's what I thought.
Retrogradely, sure.
Antegrade or retrogradely, it doesn't matter.
Yeah, but antegradely,
I mean, regarding
the
the
hydrophilic part is quite the same for both. It means that you will not go 50 centimeter inside.
Yeah, retrogradely, of course. Yeah, you are right. Yeah, 30.
Yes.
But it's still less.
experiences using Elon inside the 6 French guiding catheter?
Yeah, yes, sure.
Because I think the thickness of the catheter is higher compared to Corsair, and that's one of the reasons its pushability and trackability is greater, in my opinion. I don't know. I've used a handful of them, not that many Elon catheters, but.
So you mean because in 6 French you have less support?
No. I had problems in passing the balloon for balloon entrapment.
For trapping.
For trapping.
Okay, so for trapping, depending which guiding catheter you are using, if it's launcher or if it's Cordis or another one. Yeah, but that's why, because the inner lumen of the launcher are a little bit larger than the Cordis one. So then, but also Sevket, and you told us that the wire inside the microcatheter is an extension wire, and it works with any wire in the market. So you can use it with a 6 French, no problem.
3 times using Elon, I didn't know that the wire extension was inside Elon. After the third case, I started using.
But I can tell you it was the same for me, because I asked the APT and the French distributor why there is this stylet in the microcatheter. And I said, we don't know. And then we asked Florine from APT and said, well, it's not a stylet, it's a guide extension. So it was the same for everyone. Don't worry. So I don't know if you are any question.
Is this good performance of this microcatheter? Is this specific for this 2.6, or does it apply to 1.7?
So
Because there's 1.7.
yes, 1.7 is more like fine cross. Okay, it means it's with the new fine cross coming now. So it's branded, but it's plastic. Okay. The 2.6 tapered Elong microcatheter is really with a spire, with some, so it's more than the Corsair architecture, okay?
So where do you recommend using the 1.7?
I'm not using the 1.7. But if you can use it to cross some very tiny epicardial channel, I think, because 1.7 is like the fine cross, so it's quite around the caravel.